I've decided to even up the playing field this week with some raga music from India. Does anybody know the music on the title slide and also the odd foot out on the next slide? This week we'll be looking at heel pain. There's a lot of causes, but I've chosen the 5 most commonly seen in my practice. A couple of them I've only seen very uncommonly, but still more commonly than the ones that I've never seen. If you can pick the bones out of that statement, you're doing well. Because I would like to keep all of these webinars as shorties, or at least medium shorties, I'm only going to cover 2 conditions that cause heel pain, and we'll complete the rest next time. Hope you enjoy the webinar. I think these are the commonest causes of heel pain in the area described. Plantar fasciitis is not included as it produces pain distal and medial to this area. Fat pad syndrome is an overarching term that is also anachronistic in that pathologies are understood, so the inclusion of the word syndrome should be discarded. But like piriformis syndrome, people continue to use a term they are familiar with rather than the term that should be used. There are at least 3 separate or perhaps not so separate pathologies that cause fat pad pain, and I'll explain that statement later. The plantar calcaneal bursa is interposed between the fat pad and the skin and can become inflamed, much as you can inflame any bursa. Heel bruising is caused by sudden or repeated trauma, and it can affect the fat pad or the periosteum of the calcaneus. There are the usual 3 kinds of fracture, with a calcaneal cyst causing one of the pathological types. The first 2 will be discussed in detail in this webinar and the rest the following week. The fat pad is a true shock absorber, and it is solidly anchored to the calcaneal periosteum to prevent it slipping and dislocating. And it does its job admirably for the most part. It does thin out with age, and if an older person presents with a large area affected, that is probably what the cause is. But it has been established that large loss of the fat pad is not always symptomatic, even in old age. Generally, the structure is such that it prevents the fat pad from separating from itself and spreading, and from the underlying bone and dislocating. But both of these conditions can occur. There are 2 distinct chambers, the macro and micro layers, both of which have septae or quasi-ligaments that run through them to form small groupings of fat cells which act as baffles to prevent much spreading, and in the deeper layers to anchor them to the underlying periosteum. For a slideshow of the properties of the fat pad, go to the website on the slide and enjoy. This is an MRI of the heel. Inside the white box is the Achilles tendon insertion, and as you can see, the fat pad wraps around the back of the heel and includes the lower tendon. The round white oval shows the attachment of the plantar fascia, and the white arrows show the bands of tissue called fibrous septae that hold the fat pad in place. In health, this prevents it being dislocated during movement. This configuration is common throughout the body and helps protect the entheses. As mentioned, syndrome is probably not a good label for this condition, especially as atrophy will have different presentations to inflammation, and each will be different from dislocation and separation. On top of which, each will require different treatments, although likely all will require orthotics on either a temporary or a permanent basis. The drawing shows an artist's interpretation of fat pad atrophy, while the 2 scans show inflammation and possible separation of the fat pad. In the literature, there is very little specific detail on fat pad syndrome, and almost no attempt to differentiate the differences between inflammation, atrophy, and dislocation. Atrophy of the fat pad has been attributed to almost everything, but very few have been definitively identified. With aging, the fat pad has been found to be thinner and stiffer, deforming less in an older person than a younger person. Diabetes has long been touted as causing fat pad atrophy, but there is very little direct evidence other than it occurs with diabetic ulcers. There is association between collagenous disease, particularly rheumatoid arthritis, and atrophy, but little between most of the other cited causes. Although almost everybody concerned with foot care will cite altered weight bearing as a major cause. Personally, I've seen fat pad atrophy or inflammation commonly associated with plantar fasciopathy, and I'll discuss this as a cause as we cover that in the next webinar. For the most part, you will encounter fat pad atrophy, which may also be spreading of the fat pad. The presentations are similar, with one possible difference in cases of large spread. The patient complains of non-progressive or very slowly progressive pain on weight bearing, but that's standard operating for nearly all lower quadrant conditions. But this pain is particularly relieved when shoes are worn, and generally the tighter the fit, the better. Palpation of the heel demonstrates that the underlying bone is palpable and considerably tender. The area of bone palpable and tender is variable, sometimes no larger than a finger pad and occasionally almost the entire inferior calcaneus. If the area is small, then squeezing the fat pad from the sides reduces the ability to palpate the bone and its consequent tenderness. But if the area affected is large, then generally squeezing makes no difference. But if it does improve with squeezing, then the problem is probably one of spread rather than atrophy. But this is unusual. MRI is the gold standard, but a lateral radiograph of the foot in weight bearing will likely show the loss of a cushion, whether the problem is one of spread or atrophy. Fat pad inflammation may result from direct trauma, such as a heavy landing on bare heels, disease, and probably microtrauma via pathomechanical weight bearing and antalgic gaits. It may precede or accompany atrophy and spread, or it may be independent. If there is atrophy or spread, the calcaneum will still be palpable and tender, but the tenderness will be more severe. Otherwise, if the inflammation is isolated, then the calcaneum will not be palpable, but the fat pad will be tender on direct palpation upwards onto the calcaneum and from side to side. The pain on walking will become progressively worse with continued gait, and there is likely to be aching afterwards. Weight-bearing x-rays will not demonstrate the loss of distance between the bone and the ground if it is isolated, but may actually show increased distance due to unloading of the heel and or swelling. Inflammation should be treated the same as always. Rest, anti-inflammatory modalities, and try to deal with the cause. With atrophy or spread, the number one issue is to reduce the pain. This is done by changing aggravating shoe wear and activities. Then orthotics. These are particularly useful in small area atrophy or with spread of the fat pad. Taping to squeeze the fat pad together is very useful as an indicator of how well a heel cup will work, but often the tape works better than does the cup. For large area atrophy and spread, a gel pad to reduce the lost tissue is frequently very useful. If you suspect that the patient is abnormally wearing the pad either due to pain avoidance or pathomechanics, then these need to be dealt with. Not suspecting that the fat pad syndrome exists when treating plantar fasciopathy can lead to considerable frustration for you and the patient, as the more posterior pain does not improve even while the plantar fascia pain is getting better. Finally, in intractable severe cases, the atrophy areas can be replaced with fat from other body areas surgically. The calcaneal bursa, often misleadingly lumped with the subcutaneous and retrocalcaneal bursae, is one of two in the sole of the foot. It lies near the plantar fascia calcaneal insertion, and it lays between the fat pad and the overlying skin and reduces the friction between the two. Like other bursae, it can become inflamed either due to mechanical causes, inflammatory disease, or sepsis. Plantar bursitis can easily be mistaken for fat pad inflammation, and of course vice versa, especially if the bursitis is not too extreme and does not include palpable swelling and heat. The pain occurs with the first step and tends to be progressive with distance walked. It is improved on a soft matrix or with good insoles, and there is frequently aching after the shoe is removed. Superficial palpation is tender, and squeezing the bursa from side to side is also tender. The tenderness may extend into the area of the plantar fascia insertion. If bad enough, there may be palpable swelling and heat, but if redness is observed, it is better to think infection and refer it to the ER or the MD if the patient can be seen immediately. Assuming this is not septic bursitis and not caused by collagenous disease, it can be treated as all other bursitis. Rest, anti-inflammatory modalities, and deal with the cause. Similar to fat pad problems, antalgic gait and biomechanical dysfunctions can cause issues and should be addressed. Excessive weight bearing with poor fitting shoes may also cause issues and also should be addressed. Finally, when less intrusive treatments have failed, cortisone injections can be considered, but there is a substantial risk to the fat pad. I'm stopping here, and I will pick up the other conditions that cause heel pain next time. Otherwise, this particular webinar is going to go on for some time. Hope you enjoyed it and maybe picked up some insights into differential diagnosis in this area, particularly in the fact that not everything is plantar fasciitis. The odd foot out should be a mystery, but if it is, email me. The music is a Bengali folk tune in Dandra Tal 6 beats by Hari Prasad Charusi. And as much as I liked it, I don't understand the title. So if anybody could enlighten me, I'd appreciate it. Have a good week and avoid the virus like the plague it is. Bye.